for sure.
Awesome.
You're fine. You're
You'll
fine.
be YouTube star.
Oh yeah, that was my goal.
Okay, should be good to get started.
Awesome. Yeah, you're welcome. Well, it's my pleasure to introduce Phifer. We met, gosh, I don't know how we met Phifer, somewhere at Duke. Was it Henry?
Yeah, I think it was through Henry. It absolutely
Okay.
was. Mm-hmm.
All great roads lead through
Henry
Henry
Rice.
sometimes. Yeah. He was at Duke doing, well, I'm sure he'll talk about his training and everything, but we met here at Duke and just had some very similar approaches to life and global health that Gemini does. I mean, you'll probably hear accompaniment and walking with instead of over people. I mean, Phifer just comes by this naturally, so he certainly fits Gemini. And he went to the Sudan with Henry for weeks, and I'm sure he'll talk about that, or I'll bug him with questions at the end. But just had such an interesting experience of doing global health in a spot that you just can't get to easily, and where you really see the need the most, like multiple compounding needs. So we did a paper together on the cost effectiveness of surgical care in places like the Sudan and what that looks like that we just invited him to come and talk about. So Phifer, I could just keep talking, but I'm going to let you start us off and then we will do questions and answers at the end. But thank you for joining. It's very early there.
Oh no, it's just so lovely to be here with you all, and I'm just grateful for this opportunity. And Emily, it's really good to see you and miss you out here in the West Coast. Let me see if I can get my setup going correctly for sharing my screen with my presenter view. I'm gonna struggle for one moment. I'm sorry that I didn't log on sooner to get this all set up. Presenter view. See if I can share my screen. Should be able to see this. Can you see my presentation?
Not just yet.
Oh,
How
hit
about that?
something.
It is
There we
there,
go.
yeah.
Cool. And do you see my presenter view or the actual one?
The actual presentation.
Oh, lovely. Great. I figured it out. Well, good morning, everyone. Again, my name is Phifer. I graduated from Duke last year, about a year ago, next month. I spent 5 years there. I did medical school at Duke, and then I also spent 2 years in the divinity school in the theology, medicine, and culture fellowship. So Emily and I first met, I think, a couple years into my time at Duke, had a lot of overlapping interests and values and kind of shared ideas. And um, especially Henry Rice, who's I'm sure you all know, one of the pediatric surgeons at Duke, global surgeon. We kind of baked up this harebrained scheme to spend some time out in at the Mother of Mercy Hospital in Sudan. Henry has gone now multiple times every year to do cases, pediatric surgical cases with the medical director, Tom Catena. I spent 3 months there as a fourth-year medical student, doing both kind of immersive qualitative research as well as this really fun costing study that I was able to do with Henry, Emily, and the crew. So this was a group of folks from Duke, Mother Mercy Hospital, HMS, and then I'm currently affiliated with UCLA. I presented this a few weeks ago at a conference. So it's great to be here with you all. Let's jump right in. This presentation will be more the technical side of the project itself, but happy to dive into any and all aspects of time there, life, kind of the other larger questions that I had kind of surrounding the study, and jump right in. So armed conflict causes tremendous challenges to health systems that can be long lasting, even after acute conflict has subsided into a more chronic state. Despite the impact of conflict on healthcare systems, the global health community has not provided adequate attention to understanding healthcare delivery in conflict zones. Cost effectiveness and return on investment, or ROI methodologies, take into account both the costs and the benefits of care. Many areas of surgical care and LMICs have been shown to be cost effective and offer a high return on investment, but most of these studies are from health systems in secure political settings. Which brings me to the core research questions of this study. Is providing surgical care in an area of chronic conflict cost-effective? And is there a significant societal benefit to sustaining surgical care in these settings? The setting is Sudan. Sudan has been in a state of recurring and chronic armed conflict since the country gained independence in 1956. The Nuba Mountains, which is a region within the South Kordofan state, has been characterized by high levels of cyclical armed conflict for the past several decades and has been designated by the international community for special concern. The region has been excluded from most types of support from the national government, the limited semi-autonomous government overseen by the local rebel group. The chronic conflict in the Nuba Mountains has led to long-term collapse of the local health systems, massive internal displacement, food insecurity, loss of infrastructure, and large-scale human rights abuses. Now enter the Mother Mercy Hospital, which is a 425-bed hospital in the Nuba Mountains of Sudan. The hospital and the region and the hospital itself has been bombed several times over the past few decades by the Sudanese Air Force. Mother Mercy, hereafter MMH, was formed in 2008 in partnership with the regional government and the Catholic Diocese based in El Obeid, Sudan. The catchment area has approximately 2 million people, although there are large populations of internally displaced persons, making exact population estimates difficult. This hospital provides surgical care in general surgery, OBGYN, orthopedics, ophtho, urology, neurosurgery, and dental care, among others. It has a single budget for all operations, and as such is uniquely set up for a cost-effectiveness analysis. So for this study, we conducted a retrospective review of the surgical logbooks of all patients undergoing inpatient or outpatient surgical procedures over a 12-month period from January 2022 to December 2022, with data themselves collected from January to June 2023. We collected data on patient age, gender, diagnosis, and primary surgical procedure performed. Other data, such as patient comorbidities, complications, or clinical outcomes, were not collected. Overall, hospital budget expenses in 2022 were obtained from Mother of Mercy and African Mission Healthcare, the overarching organization that helps sustain and fund the hospital, through the ledgers and the year-end financial statements. This includes expenditures for all direct medical and non-medical costs, as well as administrative costs. Final surgical expenses included the entire amount of expenses directly related to the care of surgical patients, as well as the portion of general health system expenditures attributable to surgical care. The benefits of surgical care were estimated by calculating the averted disability life-adjusted years, DALY, based on predicted clinical outcomes for each surgical procedure drawn from established clinical studies. The DALY represents the amount of premature death or disability attributable to a surgical condition that is avoided through a surgical intervention. We estimated that DALYs for each individual surgical procedure for the most commonly performed procedure. We estimated the DALY for each individual surgical procedure for the most commonly performed procedures, and then extrapolated to the overall cohort of patients using established methods for extrapolation of economic health data. Basically, we counted up, we'll talk more about the full number of surgeries here, but we went individually through nearly over 3,000 surgical cases, and about 80% of them were the most common cases. We used extrapolation to then extend that to the total cohort of over 3,000 surgical cases, using the literature to assign disability weights, outcomes, because we didn't have actually outcomes data from this group of patients themselves. We use a range of clinical studies and data sets to inform all input variables. We note that most assumptions, such as the probability for successful treatment, the risk of death, and et cetera, were informed by clinical studies, mostly from high-income settings, as there is very little available data on these parameters from conflict settings or LMICs. We assigned disability weights based on the 2019 Global Burden of Disease study. And for conditions that did not have assigned disability weights, we use a disability weight from a similar condition. We modeled the societal economic impact of surgical care using a human capital approach. This approach estimates the societal economic losses that are avoided as a result of surgical treatment and equates the value of years of human life to the market value of the economic output produced by an individual over her lifetime. Societal economic impact is calculated by multiplying DALYs per patient times the purchasing power parity of the country which you're studying. In this case, we use South Sudan as opposed to regular Sudan or North Sudan as a proxy, because politically and economically, there are actually more ties between South Sudan and the Nuba Mountains as opposed to the regime in the north. We also calculated social return on investment, which is a framework that helps quantify the social and environmental value being created by producing a ratio of that states how much social value in monetary terms is created for every unit of investment. This is represented by the formula overall societal benefits over overall costs. We use one-way and two-way deterministic sensitivity analyses to test the impact of uncertainty of all input variables in the upper and lower bounds of the cost effectiveness and societal benefit model outputs. A total of 3,016 total surgical procedures were conducted at Mother of Mercy in 2022. The most common types of surgical procedures were in general surgery, ophthalmology, and OBGYN. The overall annual and surgical expenses at Mother Mercy are listed here. The total overall expenses was about $2 million. I won't go into depth with all the small numbers just for the sake of time. And then the results of the bed survey found that 30.9%, basically 31% of inpatient hospital beds were for surgical patients. So we attributed about just shy of a third of overall hospital expenses of that $2 million was specifically dedicated to surgical care. Now, moving on to the overall results. The benefit of all surgical care at Mother Mercy over the 1-year period was 8,774 averted DALYs, with maternal health, general surgery, and orthopedic surgery accounting for the most DALYs. What does this really mean? So the most important thing is the average cost effectiveness ratio for all surgical care at Mother Mercy was 72.54 DALYs. So you take all the DALYs, all the money divided by like the money for the entire hospital, and you divide that by the DALYs averted, $72.54 for every disability adjusted life year averted for this hospital. This is far less than the GDP per capita of South Sudan, which is $585, qualifying it as incredibly cost effective by World Health Organization standards. We found wide variability in the cost effectiveness ratios by surgical specialty, with OBGYN, plastic surgery, and orthopedic surgery the most cost-effective specialties. If you look at this chart here, they have the lowest cost-effectiveness ratios. A low cost-effectiveness ratio translates to a highly cost-effective intervention, with dental care or OMFS being charted and found to be the least cost-effective specialty in our study. The total societal economic benefit of surgical care was found to be $7,366,000, which extrapolates to total benefits when we extrapolate to all surgical procedures that accounted for in that surgery at Mother of Mercy to $9.1 million. These economic benefits lead to over a 14-to-1 return on investment ratio for each dollar invested in surgical care at Mother of Mercy. Sensitivity analysis showed relative confidence in both the cost effectiveness ratio and societal economic benefits models. By one-way sensitivity analysis, the use of discounting and uncertainty in extrapolation costed cases had the highest impact on the greater upper and lower bounds of the cost effectiveness ratios and societal economic models. Basically, with our one-way sensitivity analysis, assumptions that we made with both our extrapolation methods as well as with the uncertainty in the variables that we chose for each input variable for our DALY conversions, for cost effectiveness conversions, those are kind of for the most variability that we had in our study. A two-way sensitivity analysis showed the lower and upper bounds of the cost effectiveness ratio in societal economic impact models by varying all input variables simultaneously. Even with a worst case scenario with the highest level of uncertainty of all input variables, the upper bound of the cost effectiveness ratio is still far lower than the GDP per capita of South Sudan in 2022. In conclusion, in our study, surgical care at Mother of Mercy was very cost effective by WHO standards and is comparable to common public health interventions such as antiretroviral therapy for HIV and bed netting for malaria prevention. Given how fragile global economies are within conflict zones, even modest investments to support surgical care can markedly benefit the health and economy of local communities. We do not suggest that provision of surgical care in conflict-affected regions should be based entirely on the economic value of care. Humanitarian action itself is a fundamental moral activity grounded in an understanding of healthcare as a human right. Our findings suggest that surgical care in this conflict setting is not only morally just, but also very cost-effective and may offer substantial economic benefits to help rebuild fragile communities. Importantly, our findings show a 14-to-1 ROI ratio in this conflict-affected region, which is even higher than the often cited 10-to-1 ROI ratio for surgery coverage globally that was put forward by the Lancet Commission on Global Surgery. Our study has a number of very important limitations. I'm actually going to spend quite a bit of time on this slide just because it is important to talk about this together as a community. Most importantly, as with any economic modeling, the validity of the results are dependent on the choices and of the underlying assumptions, accuracy, and uncertainty of the input variables. So for example, when we were going through this study, we coded every individual cesarean section with a disability weight congruent with obstructed labor. And every amputation related to diabetes, every amputation with a disability weight of something related to diabetes, because we didn't have a proper disability weight for it, or that seemed to be the most consistent clinical kind of outcome. For example, and I'll speak from my experience there on the ground, having spent 3 months there. I was scrubbing into every OR case with Dr. Catena for the 3 months that I was there. Most of the cesarean sections that were being done were either being done in women who had come in extremis, who did have obstructed labor. We actually had one woman who perforated her uterus while I was there, which is a very, very, very rare complication to have in a high-income country, but happens relatively frequently there. Most of the women in Sudan and the Nuba Mountains have upwards of 10 pregnancies in their lifetime, or the C-sections were elective because these women had had multiple cesarean sections in the past, and their risk of either obstructed labor or of perforated uterus was so high. So we coded that with a relatively high disability weight, which potentially overestimates the actual economic impact of cesarean section, which was the most common procedure done at Mother of Mercy. But to try to offset this, we coded all the dental procedures, which was actually, I should say this by number, the most commonly done procedure was tooth extractions. We coded every single dental procedure as a mild dental health condition, which likely far underestimated the cost effectiveness of dental care. And that's reflected in the really kind of poor cost effectiveness ratio of dental care. So we tried to offset this with different surgical interventions that seem to be from our experience on the ground and from our knowledge of clinical care and our experiences in the literature. We coded those higher, and then we tended to code other things lower to try to offset the other two. We also use predicted clinical outcomes rather than primary outcome data because primary data was not available in this setting. Further, disability adjusted life years, or DALYs, are designed to measure the burden of health conditions at a population level, not at an individual level. An accurate estimation of economic benefits from individual surgical procedures, one procedure done on one patient at one time, is really challenging to do. And that was an assumption that we made in order to make this study possible. We also used a 5-day bed survey to basically estimate the total number of surgical beds that are attributed to each patient, and then use that to assume or estimate what percentage of the funding of the hospital goes to surgical care. That is an assumption that was made by us. In our sensitivity analysis, this actually showed relative confidence in our assumption because we based this off of regional and seasonal variation in care and healthcare seeking behavior based off of the season, whether it's rainy or dry. We also estimated the benefits of surgical care as averted DALYs only from surgical procedures, which does not account for the additional benefits of non-procedural surgical care, like multiple burn dressing changes or other smaller procedures that are done on the floor that aren't done by medicine physicians or kind of within the realm of medicine. And so that actually potentially underestimates the impact of having surgery at this hospital because we didn't capture all the different ways of having a trained surgeon and a surgical team and a surgical staff, anesthesia, to be able to offer both high value care and excellent care for this population. Lastly, we assumed that costs were equivalent across all procedures to facilitate our analysis. Although this led to overestimation as well as underestimation of the cost effectiveness ratio of different surgical specialties, our sensitivity analysis found that it did not affect overall findings. In conclusion, we found that surgical care provided at Mother of Mercy within a conflict-affected zone of Sudan is very cost-effective, providing substantial societal economic benefits and has a high return on investment. Although our case study was conducted in a single setting, it does suggest simple policy recommendations. One, in regions of acute as well as chronic civil conflict, healthcare planning should include support for surgical services. Two, modest investments in surgical care offer tremendous value for money to address health needs in conflict regions. And lastly, expansion of surgical capacity in the Nuba Mountains region of Sudan may provide a cost-effective approach to address local health needs and improve the regional economy in this fragile setting. I'm grateful for your time. I'm going to run through my references quick here, and then I'm happy to receive any questions and start a conversation with you all.
Thank you, Dr. Nicholson, for the presentation. I always find this cost effectiveness evaluations so heartbreaking when you see all the impact they could potentially make. So let me open up the room for questions. Otherwise, I'll start by asking you one. Anybody have questions?
I have a question. So great presentation, Dr. Nicholson. I thought this was a really interesting discussion and really cool data. So really nicely done. Congratulations to the team. I'm coming from this from a trauma standpoint. We know that trauma outcomes are markedly worse in low and middle income countries compared to high income countries. But I think I heard you say that you modeled outcomes, like expected outcomes based upon high income country outcomes. So what do you think the impact of that is? And is there any way around that? Because the outcomes can be very different depending on the surgical procedure performed.
Oh, absolutely. And this is, it also kind of, I didn't even get into the way that surgery is really delivered there. It's really, so I'll start with just kind of explaining the hospital itself and then explain why we modeled it that way and the ways that actually would have affected our data in my view of how I understand how we came through with this. So Mother Mercy's medical director, Tom Catena, is the sole kind of surgeon there at all times. He's an American trained physician who's been there now for nearly 20 years, is now married to a local person. They have, they've adopted children from the Nuba. So he's very much like a part of that place. And he is kind of one of those old school, I read that article, I think in the BMJ Global Health about a year ago, talking about a rural surgeon in India who kind of does everything from thyroidectomy to trauma to abdominal operations. Basically, the only things that he doesn't do is vascular, thoracic, lung resections and esophageal work, but otherwise kind of head to toe will do most surgeries. And then there are also visiting surgeons that come in to, Dr. Rice will come in and do pediatric surgical cases, for example. And then there's also folks who cover when he's away. And then there's local staff who will do minor procedures. So with regards to it's a really, really great question. And I think I'll use, as a general surgeon, I'll go right to inguinal hernia. Bunches of inguinal hernia operations at this hospital. We don't have individual patient outcomes for each of these. And so we used kind of large MSQIP-based hernia outcomes to talk, to kind of discuss what is the rate of complication, the rate of recurrence, all of those things. And I think in many ways, it's hard for me to say because I was there for 3 months. I don't have actual data about the outcomes from this hospital. By what I saw, the outcomes were good and things went well, but I can only speak to that from, kind of a personal experience level. But I think in many ways, because we a lot of the cases that you're doing. So for example, the hernias that we were doing there were sometimes like large like hernias herniating down to the scrotum or down to even like the knee. So there are large ones that in the States would be this very large complicated procedure, but that's kind of an average hernia that comes in. And so I think that the level of complicated nature of the cases that are done there are actually higher there than in the States a lot of the times, and where a lot of these data is drawn from. And I think that the oftentimes, for example, something like with C-section, a lot of these women are coming in the extremis. They're very, very sick. So I think that we actually likely probably had maybe a slight bias towards overestimating the kind of the outcomes maybe were a little bit better in the studies that we used to model this than what they probably look like on the ground there. And that's not because the care itself isn't excellent at Mother Mercy, but because the individual, the capacity of the hospital and the nature of the complexity of the conditions are actually oftentimes higher than what we're seeing in high-income countries. People are coming in later, a lot sicker. And you're not, for example, with trauma patients, and we did have trauma patients in this study. Dr. Catena has seen a lot of trauma there, unfortunately, because of the ongoing conflict, but there's no surgical ICU, for example, afterwards to receive a very sick patient. And so I think we probably had a little bit of a skew towards overestimating and kind of like maybe having a little bit better outcomes from the literature that we found than what we actually see on the ground there.
Do you think that then impacts its generalizability to other low and middle income settings?
I would say that it probably, I think that I would actually say that what impacts our generalizability to other settings is the very unique funding structure of the hospital, where it has basically a single stream of funding through African Mission Healthcare and through the church. And so it's very, 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 it runs at a very, very low cost. It's a very like well-run, efficient hospital. I think that's probably that's the most difficult generalizability that we have. I would say that if we're able to demonstrate cost effectiveness at this level and at this place, I think that as long as we use similar the best would be to have individual patient outcome data for each patient. That would absolutely be the kind of gold standard that we would want for these type of studies. But if you were to kind of carry over similar methodology to other places, I think that it could be possible. And I think the methods themselves could be generalizable in a sense. But I think the uniqueness of this place and our and the way that we went about the study and gathering that could hinder that a little bit. I still think that the numbers were so impressive, and we tried to account for that likely overestimation there with kind of tempering and temporizing our variables and inputs in other ways. So we think that our sensitivity analysis caught that as well.
Very cool. Thank you.
Thank you.
Phifer, I'm wondering if you can give a more of a higher level discussion on cost effectiveness, because I have such an internal debate on should we use it or not, because it is. And if Phifer, we just had Dr. Jim Kim speak here last week on, and he mentioned cost effectiveness. Like it just does not make sense from a human standpoint. I agree with it. At the same time, you have to demonstrate ROIs. And I mean, the world is just predicated on that, from the World Bank to the WHO.
Yeah.
So I'm wondering, I mean, living there for 3 months, like how did it, I don't know, however you want to answer that question on how do you wrestle with that?
Yeah.
Been on the ground in a conflict zone that is still experiencing
Yeah.
some significant upheaval.
Yeah, absolutely. I'm grateful for that question. And that was a kind of burning question in my mind throughout both the collecting of the data, the kind of labor of putting it through, of rewriting it and editing it, and the initial draft and everything was, I know Dr. Catena and local Nuba staff well. I spent a lot of time with them. They became my friends, and they're going to do this whether it's cost effective or not. I think that if we had found that this was not cost effective, they would have said, all right, we're still going to offer this care. It's the right thing to do. And so I kind of grappled with, so what are we doing here? Why are we doing this study? When we offered it, we had the idea, Dr. Rice and I, when we were there. And when we said, here's what we're thinking about doing, we think this is probably going to be very cost effective. What do you think? Dr. Catena and John Fielder, who kind of helps with the kind of funding of the hospital itself, jumped all over it. They're like, absolutely, do it. We need this. This will be very helpful. So I think that the reason being, Emily, like what you said, is that the language within a lot of these spaces is predicated around being able to demonstrate economic benefit and cost effectiveness. So I am actually deeply troubled by the fact that that's the language and the currency that you need to be able to demonstrate and to be able to show to these kind of folks in high places to be able to kind of justify what I view to be, and I tried to signal to this in our conclusion and then the draft of the paper itself, where it was like, I feel like we need to just mention that regardless of what the outcome was, it's the right thing to do. But cool, awesome, this is very cost effective. We should continue to go forward with it. I think that's what the Lancet Commission did back in I think it was 2015, right? That was like the kind of one of the core aspects of the Lancet Commission, was that it's both the right thing to do and it also is cost effective. So I think it's I've grappled with it. It's something that I've thought about a lot, and I think Emily, you kind of signaled accompaniment earlier. I think about Barnabas Allende, and his language around the kind of old proverbial teach someone to fish, they'll fish for a lifetime, and he said, why don't we just fish together? And why don't we just sit alongside each other and work together? And I think that this hospital is a really kind of paradigmatic example of accompaniment in a very difficult circumstance. If it wasn't cost effective, they do it anyway. But I think that the value of these studies is they've been able to use this to share this with funders, and it helps them do their work better.
Yeah, good. Thank you.
Yeah, Emily, on that point, I was going to make a question / just discussion that it always feels like this kind of study, I agree, they're very important to highlight the argument of the importance of the field, but it also feels like every time you look at it from a societal perspective, it's always going to be cost effective, because you're assuming in the model that you're reducing deaths that are premature. Yes. And therefore you're losing all this massive production.
Yes.
So besides bringing in the attention, I feel like one of the gaps that I think the surgery world there's still a big gap on it, is making these evaluations that are more targeted to actual feasible interventions beyond the rationale that we just need to do more surgeries. I think that's, as you were just saying, Dr. Nicholson, they will do it anyway because it's the right thing to do and it's what needs to be done. And this number kind of draws the attention to how important it is from a societal perspective. But then you go back and say, okay, so how do you change this? And then now you have this massive political engagement and investment in a world that is just not sharing resources appropriately for historical ages, and that's not going to change in a short term. So then what is the next agenda from it, in the sense of, yes, there's this massive economic impact that lack of surgical procedures is impacting. What is the agenda? How do you fix this in a way that is feasible, that doesn't really require a change in the whole country structure that is not going to happen?
Yeah, no, that's a really insightful question, and I think the expert on that is going to be Emily, but I'll kind of give my kind of initial thoughts. Yeah, the fact that one of the reasons that I think this hospital and kind of our study is notable and stands out is that despite the kind of extreme nature of the circumstances in the region and in the Nuba Mountains, and the high cost, the human cost of running this hospital is extremely high. Even if it's very, very cost effective, it is very, very challenging to keep this hospital going. The logistics of getting medications in, the funding streams from all different sources. They had a food program that I think was kind of on the rocks for some time. Like it was kind of come into a close with the UN, but that was a US based USAID program, and of course now that's all gone. So it's very, very, very difficult and challenging and tenuous to kind of institute kind of these large level changes in places. I don't know how, I don't think that anybody, I think focusing on like this place and this hospital, I think what I've been so captivated by with Mother of Mercy, with Catena, with the Nuba trained staff who are there, is their commitment to provide an alternative, to kind of embody an alternative to the violence that and the kind of instability that is that's kind of been characterizing that region for some time. So I think my answer, and maybe this is a little bit of a kind of like punt, but I really don't think that it is. I think when I've looked at, kind of like global health crisis, especially conflict zones and crisis zones, places like Gaza, places like the Sudan, the answer that I've had is, of course, we need people to be kind of working and lobbying at a higher level to both like stop the conflict and find peace and enable for these places to start to kind of develop and grow themselves. But it also, I think, requires individuals and communities who commit to stay and who choose to go there, and kind of this accompaniment ethos really just says like, I'm walking with you wherever you're going, and I'll stay as long as you want me to stay. And I'm not going to retreat to some kind of safe enclosure within whatever space that I come from or however I can escape. And so I think that my answer right now in my kind of like small, like kind of like piddly life is to say that we need to kind of like lift up stories of folks who decide, despite the challenges that we face, to say like, we're going to do this anyway. Come hell or high water, and we're in this together. That's my answer right now, and that's much more of a kind of like I would say kind of like ethical kind of framing that's not really necessarily in the language of kind of like large kind of high money, high value global health spaces. But I think that that's where I would start. And then that from that commitment then flows, I think, a kind of alternative way of doing things that can actually change outcomes for a long time. And I think about something like there's a really great study, and I'll send it with Emily and she can share it with the group. And there's probably a lot of folks who can understand the economic modeling better than I can. They modeled the outcomes of rural hospitals, and especially they actually looked at Protestant mission hospitals in India from like I think the late 1800s on, and a lot of them have now gone away, but they were able to model that in those areas where those hospitals were built, there still continues to be a durable change in health outcomes based off of those like institutions having been planted there, and changing kind of entire ways of seeking healthcare and engaging with healthcare. Maternal mortality is lower, child mortality is lower, and all those things. So I think building institutions in places and planting them and committing to them is right now my best response to the kind of larger level question of how do we actually make change.
Thank you very much. Okay, I'm gonna move us on unless there's one final question. I think we're in time to move to the next part of our meeting. So Dr. Nicholson, thank you very much for your presentation. Thanks for coming. I want to point out that Emily shared some more publications on the chat that would co-accompany with this discussion. This is a fascinating work. We'd love to have you come again and talk more about your work and other initiatives that you're doing. Congratulations on the work so far.
I am so grateful for your time, Emily. Thanks for inviting me. You've been a wonderful and generous audience. I'm so thankful. I wish I could stay longer. I have to go and finish making the rounding list at the VA this morning, so I'm
Sure.
gonna run. But I'm grateful for you all, and I hope that we can see each other again soon.
Yeah, you're always welcome. Thank you very much.
Thanks, Phifer.
Okay. All right. Yeah, let's turn down the YouTube.